questions. I wondered whether there were anyone in the audience, I can see Gil there as an expert in leukodystrophy, who had any particular areas that they'd struggled in with the families in terms of obtaining support or dealing with difficulties. Would anybody like to shout out any areas that they've had problems with? Dystonia. Ataxia. So imbalance of tone and ataxia, posh word for being unsteady when you're walking, tripping, falling. Nice cover that by Dr. Ali next door. Different causes. The breathing difficulties, lovely. So breathing difficulties, swallowing secretions. And Gil, what were we discussing outside the lift? The diagnostic odyssey, getting an efficient diagnosis, and then maybe seeing the right person at the right time. Is that what you told me you'd had problems with? Lovely. I love that saying. Karen, we want medical villages. Okay, that's a really lovely idea. That's what we need. So I'm going to talk a little bit how you get that medical village around you and some tips in the area and a couple of spoiler alerts that I'm not going to fix the problem. And if you do have a child early in your journey, and we're talking about dystonia, remember it doesn't mean your child's going to get dystonia. I'm going to talk about problems that are common but don't occur in everybody. So we don't treat statistics, we treat children. So I apologize if I worry anybody with any terminology, but please catch me in the lunch break if there's anything you're not sure about. So the initial presentation in the UK would go to your primary care physician, as the Americans would call them, a GP we would, and hopefully referral to the pediatrician, which we know can be highly variable in how long it takes to get in. Hopefully a prompt onward referral and diagnosis, and we might talk a little bit in a second what do you do as a family when things are not running as quickly as you think, even after you've spoken to Karen and she says, no, this is too slow, we need to speed up. So there can be a delay. And this is an example of a condition where, which is a typical slide for the dramatic inflammatory changes we get in adrenal leukodystrophy. So this is the white area that I think you can all see at the back of this MRI scan of a child's brain. And this is the situation we're all trying to avoid, so that when boys are having a medical problem, they're picked up, diagnosed, and treated prior to this developing. So time is of the essence, but I would argue that time is also of the essence for other things, the dystonia, the sleep, the breathing, and all the other issues you've raised. So you will go through the early diagnostic odyssey, and that's not part of really what I'm going to concentrate on today. And the genetic tests may identify things. Hopefully you'll have some metabolic analyses that will splice in. And then a diagnosis. And Gil was telling me about his own journey with a diagnosis was quite brutalizing in where it came in like a nuclear missile. And it can be it's likely to be of a very rare condition and frightening for those two perspectives. What happens next? Well, what should happen is lots of people should then arrive promptly. And I wondered whether people could shout out the names of the type of people who might be needed within the next weeks when a child is diagnosed with a probable leukodystrophy. Because for some of the cases, you'll be told, this is the direction we're going in, we're working them up. But you wouldn't necessarily need to wait for the diagnosis if your child's got a dystonia, because we could get on and treat the dystonia, couldn't we, while we're waiting for the metabolic work. But who else might arrive or need to be in that medical village other than the GP? A neurologist? Now, Lydia, are the neurologists the critically important part of this journey? Okay, so I want you to take home that message. There's 2 take-home messages, and Karen gets me in terrible trouble when I give this lecture, because apparently someone took the take-home message of never using medication, which is a recurrent theme, because the medication doesn't fix things. But the neurologist is an important part of the group, but it isn't. It will not possibly be the most important person. The most important people will, of course, be mum and dad or other carers in the local community. Anyone else other than the neurologist? Social worker can be invaluable, and their input or output is variable depending on the problems. Anyone else? Children's community nurses can be absolutely invaluable. They're normally, in a failing package, it's normally their absence is the reason it's failing. Carry on. The symptom management nurse, lovely. So I've spliced them into the talk. So they come from something called the hospice, which is a frightening, because those of you who've had elderly relatives know you go to the hospice to die. But in pediatrics, the hospice basically doesn't deal with end of life. They deal with complex care. And the symptom control team are embedded with them. They are really useful. I'm going to whiz on. So I thought about the secondary level pediatrician, and had a lovely story about some problems with neurologists, and it sounds like you were saved by a really nice local paediatrician. What we need to be careful with them is they don't drown underneath this. The many different therapists. I don't think anyone mentioned the physiotherapist. Anyone been involved with a physiotherapist? Lots of hands coming up. Any other types of therapists? Speech therapist, anyone, other ones? Occupational, and bearing in mind Pujit was in the room, we have to remember our psychotherapists and psychologists as well, and for well-being. So a radiologist might come in, so we've heard the lovely talk from the scientific group, Kish. The neurologist, we are very useful at signposting. We must be in the loop, but not to lead care is a critical point. When we are leading care, it goes wrong in my experience. Endocrinologist, and that's an example of other specialists who might need to come in, but not lead care. So knowing if you need, and the typical ones I think we often need is orthopedics and gastroenterology. And just knowing where those services come from can be really useful, because if you come in somewhere like London, you might have something a bit odd. You could be living in Hampstead and find that your neurology is from the Royal Free, but the orthopedics comes out of Gosh. So just being clear on where those routes are coming from is useful. And you as a parent on the early part of the journey don't need to manage and know all that. But it's just having some understanding that there will be people coming in different directions, and that's where the neurologist and your local paediatrician will be really useful, because you may feel somewhat confused about who's doing what, but that's their job to signpost people in the right direction. I might ask you, there are 2 types of paediatrician. Does anyone know the 2 main types of paediatrician, other than good and bad, but carry on? Bald and hairy? No. Community and acute. So the community paediatricians aren't available out of hours, etc., but they're integrated via developmental centres with physio-occupational speech therapy, and some of the problems you talked about a bit earlier, that's their area. The acute paediatricians may well be needed, and ideally you have a name one of both, and they tend to get involved when the child's in hospital, but the community paediatrician will be aiming to keep the child out of hospital at all times. When you go into adulthood, this changes a little bit. And do you know who takes over from the community paediatrician? The GP. And often I think people are worried about engaging with the GP, but if you bear in mind that 80% of their workload will be the frail elderly who have problems with breathing, mobility, dystonia, spasticity, reduced cognition, you can see they have quite a high degree of expertise in the area, but might need good communication and rethink at that age. So we talked about the parents and carers being the critical part of this team around the child, or the Harrison village. We still need the GP and local team, e.g. health visitor. Why do we want the GP in with kids? Anyone? medication prescription, spot on. They will need to do that. Now, if you pitch up and say, my child's got metachromatic leukodystrophy to a GP, how is the GP going to feel when you use that terminology with them? Worried. So I think it's then one has to be clear, and as a parent, I think in making sure that there's evidence that the GP is being empowered on what they do by the local paediatric services. And if that's not happening, then I think, to a certain extent, it's a good role for a parent to advocate for the GP that they don't feel they've been given the correct information. And do you know how that would work in practical terms, how one might engage the GP if they're unsure what they're doing? Ask them to talk to the paediatrician. How would the GP talk to a paediatrician? They're both super busy, they've both got hundreds of things going on each day. How's that going to happen, anyone? Well, you could do email, 500 a day each one gets, and unfortunately they'll be dealing with the resus ones. So that's when we have something called an MDT. Anyone know what an MDT is? Yes. Yes, and the MDT meet. And the joy is, paediatric services have had a nuclear missile called the pandemic, when basically the country had a decision whether they were going to concentrate on the welfare of the frail elderly and forget the kids, or do the kids, and they voted for the frail elderly. So paediatric services have had a big hit in the pandemic. But one of the good things that came out of it is the MDTs are now held mainly online, which means they're very easy to organise, and we can have a low threshold for doing those. So what works really well, if any member of the team seems to be has lack of confidence, the first thing, everybody here is going to be dealing with an ultra-rare disorder, and we have to be realistic with our expectations, and that MDT meeting is a fantastic way to empower people and reassure them that they don't need to be looking at the molecular genetics of the ABCD1 gene if they're a speech therapist. They just need to concentrate on the swallowing ability or the food consistencies and things. But the main coordinating paediatrician is essential. There is a postcode. I mean, West Suffolk has the best paediatric care in the UK by a long way, because Jill Gordon is there, and she is simply a marvellous community paediatrician. She's older than I am, and I've retired. So sometime in the next couple of years, Jill will step down, and they will have someone coming in who has a lifetime left experience, and then will not be very confident. So there is a variability there. And I think there may also be a turnover, mat leave, retirement, and things like that. And hopefully your child or you will live a long time, so you will be going through different people in that role. But the coordinating paediatrician is normally best done by a community paediatrician, of which about a third have formal training in neurodisability. The therapists will be on it, and I put these in small italics, the specialist paediatricians such as myself, or James, and although we do have an essential role, it's so important to focus on that local village, which we take holidays in, but we're not actually long-term residents as specialists. So almost no problem is specific to leukodystrophy. And all these issues you've raised are just seen routinely. And in fact, in practical terms, with a child who's got a very severe leukodystrophy, in the problems that come to clinic, they're very similar to a child with a high level of cerebral palsy, which is absolutely routine within paediatric practice. Yes, there will be some differences, e.g. with a leukodystrophy, they have adrenal insufficiency. But actually, no child with CP is the same. We treat children, not statistics. So actually, looking at the problems is what we need to do, rather than being overwhelmed by molecular genetics or biochemistry and things like that. And these teams will have been very successful at teaching these children with other labels. And I have a few children who I've said to the team, just tell them they've got bad CP and they'll know exactly what to do. And that in some ways has worked quite well. So there is a national service for inherited white matter disorders now, and it's been brilliant that Rahul and Lydia are here. So, should you go straight there, or should you not? Yes and no. So I think it would be fair to say I would strongly encourage everybody should visit a specialist such as Lydia to have overview of their child's leukodystrophy. And I think when that bubble has been lanced, people are much more comfortable with the secondary and the local services. So I think it would be fair to say I've seen more leukodystrophy than you have, Lydia. But I'm not the leukodystrophy expert. But I think the parents I deal with feel once they've been to Lydia's team, or in Cambridge it would be down south to Rahul at the Evelina, they then feel that comfortable with what I'm doing. They're not missing anything. So I think getting in early, and as a specialist, I'm very keen that we just check there's no disease modification therapy that should start urgently, like gene therapy and things like that. But once that's been done, it's very important to backtrack from that and make sure that local service, and there will be I was one of the people who put together the commissioning for the IWMD, and as part of that isn't managing the child any day-to-day problems. It's really diagnosis and urgent transfer to disease modification therapy if it's there. So coming through some practical things, I've put sleep as number one, and I'm not sure if whether that rings a bell, but anyone in this room getting broken night sleeps? There we go. So I think that's something that's ranked up and up and up. So sleep disorders are common in children with CP. Your child will be one. There'll be, to every one of yours, there'll be 100 kids with CP in your region, and that's something the community pediatrician does routinely. Ultimately, for some of the children who have a very high level of disability, you may need a night carer who's coming in. We have I have families saying, oh, nights aren't too bad, I'm only up 5 or 6 times. How long for? An hour. When between midnight and 6, so that's the whole night gone. So, ultimately you may need additional support, and that's which team, if you needed a night carer to give you some support overnight, would you need to engage to get that? Continuing care will get you into that, but how do you access continuing care? Perfect. So I don't need to give this talk, Karen. Honestly, I'm wasting everyone's time. You're all coming out with the answer. But that's social worker and continuing care. This year, 2025, the continuing care will be called symptom control. These names change, I'm afraid. But that's where someone like a social worker and the community nurses are also invaluable, because it's not fair in you to expect you to know that the continuing care that was in this building here is now called symptom control in that building there, and all the paperwork you've done is redundant. That's what the social worker and the community nurses will do. And what have I put in red font right at the bottom? Medication in isolation may not help. So you're going to get that recurrent theme that medication can be useful, but if you want to quality check your community pediatrician, if you tell you're having terrible night's sleep and they said take a prescription for melatonin and come back in 6 months, that's a problem, because they shouldn't do. Although melatonin can be very useful as well as other interventions. Eating, I think we heard, feeding is a problem, and the swallowing muscles can be affected. Children will initially, as if they are having difficulties, would effectively reduce the age of food they're having. So it's going on to the kind of purees and easier foods that both children have, but also coming back to it, it's similar to the elderly, isn't it? As my mum got very frail in her 80s, we were careful what she ate. So it's doing the same journey. And in particular, I think watching a weight is really useful. So, children should be gaining weight. And if they're not eating well, firstly, they may be choking and getting unnecessary chest infections, having distressed feeding time, really impacting on quality of life. And once your weight goes down, it means they're chronically hungry. And, if you're like me, who likes to eat all the time, it's not nice being hungry. So that's the dietitian, the speech therapist. And for some children, they may need tube feeding. And if you need tube feeding for more than a few months, in general, your quality of life is much better with a gastrostomy than the nasal tube. There's no rush for a gastrostomy, but one of the reasons we often put a gastrostomy in is so that we can encourage oral feeding. So the gastrostomy doesn't stop you feeding orally. It works quite the opposite way round, actually. But we find for some of the children, we can't get anything like the calories they need orally. In the oral, everything is doing badly. So in general, some of them may benefit from a tube feeding specialist, such as a gastroenterologist or a pediatrician dealing in that area. We've already heard about dystonia. And this is a good example of how parts of the brain, other than the white matter, can be affected. And that's something that we need to keep a vigilant eye out for. And support for that, again, medication works poorly, although most children will get some. But what we do want for that is early physio assessments, and in the light of that, specialist equipment. So these wonderful wheelchairs I've seen today, and the huge one I think is not here, the lad in the wonderful armchair, basically, mobile armchair, which was a great one. But the OTs will help with that. And there's a posh name for equipment called orthoses. So if you're not sure what an orthosis, it's just a posh name for equipment, because doctors like to sound posh. And there's plenty of help, from better seating through to specialist vehicles. If you're going for a specialist vehicle, you might get some financial support for that. Just remind me where the financial support for a specialist vehicle might come from. There's a different axes to it, but the mobility component of either DLA or personal independence payments, very useful. And if you're struggling with getting disability living allowance with a mobility component or PIP, who might be a resource to support you in that journey? Karen? Yes. So Alex TLC will definitely support you in that journey. How long is the form for DLA now? Very long. Okay. I mean, I'm kind of cool. I had to do it for my mum a couple of years ago, one of the forms. Actually, I quite liked it because it helped me go through her disabilities, actually, and I found that itself educational for me as her kind of main carer and care coordinator. But who do you signpost to that if they're needing a bit more help in their local, if they were in Norwich and they're struggling with DLA, who would you signpost, Karen? The social worker for that. So that, coming back to it, yes, we do want a social worker, but the social worker discharged them. Why did the social worker discharge them, Karen? Well, they shouldn't have done, but they felt there wasn't a role for them. So we just need to, that's where you as parents can say, I do feel there's a role for you, I do want you in the loop, and if you're not sure about it, would you mind if Alex TLC or pediatrician, and if you feel this isn't kind of coming together in an active way, just remind me how we would get everyone together. The MDT meeting again, so this making sure the social worker's there, and then people can understand what they shouldn't be doing or what they should be doing, because we're using J.K. Rowling's sorting hat, aren't we, in the MDT? Okay, I'm doing dystonia, I'm not doing feeding, so these types of things. Otherwise, what we find is 10 people are doing one thing and no one is doing 9 out of 10 things. I think as vision and hearing deteriorates, this often leads to distress, and I'll come back to distress in a second, but early referral to visual impairment teams are really useful, and that's a point where you may well engage with teachers and orthoptists and people like that. But distress and irritability, is that an issue that people have had with those of you who are caring for children with leukodystrophies? Have you had periods of distress and irritability? I'm getting a lot of nods there. It's very common, very, very common. And I think you need to predict you'll go through it. And it's not easy to solve. And I use the analogy of the very colicky baby, but I seem to be the only person in the country who's had a very colicky child. So whenever I say that, people go blank. I think it's something people forget how colicky your baby is in the first months of life. But what I want to emphasize with the colicky baby analogy is to say that there's no fix for a colicky baby. They scream a lot, and then you have to adapt around it. And I think with a child with leukodystrophy who's very irritable and distressed, you shouldn't be looking to completely fix it, because there lies madness, but you're trying to improve it. But except they may go through periods of distress and irritability, and then we have to work out how the family functions even while that's happening. But the key ones we tick off are pain, and in that situation, think about areas that they may be in pain but can't tell us, so hips, bum, constipation, boredom. School and other people can be really useful there, and then making sure that, you know, they're too distressed to go to school. No, the school is essential for the distressed child, so we need to configure the MDT to get them there. Respite can be useful, although I've seen a relentless reduction in its availability within the UK, and also high variability in postcodes. And this is an example of another lad who we treated with his irritability with going for a walk while his visual impairment was very severe, and that greatly helped him. Social care, we've mentioned, are really important. And I was going to ask you who this was, but you've already said it. So the new kid on the block is the symptom control services. They can be invaluable for all of these issues. They have a number of scary titles, but do not be put off if their home address is the hospice, because that's where they're based. I'll reiterate what I said earlier, that children do not tend to have end-of-life care in hospices. It tends to be an anchor point for very complex multidisciplinary care, and they sometimes have access to services that no one else does, and the characteristic one would be respite, but they're also very good now at activating more specialist support for things like dystonia and feeding, and quite often I get contacts from hospice doctors that I've been in to talk about respite, but this kid's very, very stiff, and I'm wondering whether referral to the Evelina would help. So the team we talked about earlier was child and family, obviously central, the school GP, community nurses and social worker, the district leads, that's the paediatrician, often a community paediatrician, who may also be called a neurodisability specialist, and all those different therapists you identified. And then regionally, if there's a problem, you can go and see, but not for regular visits, movement, epilepsy neurologists and symptom control. When I'm saying not regular, you're welcome to, but normally you don't need to. And what happens is parents have limited bandwidth to go, so they need to focus in on the right people at the right time, otherwise you end up seeing the wrong person. And of course, the National White Matter Service is fantastic, but as Lydia, who leads in that, will tell you, it's much more of a diagnostic journey, and then touching base if there's a question that can't be answered regionally. I'm sure you'd be very happy to take a query, but quite a lot of those may be emailed from the relevant doctor. So, in summary, build that team, but no hurry. You're not having to build the team, but it should build around you. And if it's not building, have a think as get help, ring Alex TLC to say, look, I'm sure we should have an MDT and they're refusing to do it. How do I deal with that? Use family local services centrally. The local paediatrician is important. Use key professionals judiciously. I've said medication rarely works in isolation, but I've put my last one is it can be very helpful. And just one of few areas as an example for drooling, stiffness, sleep and seizures, but be very careful to try and avoid inflation of drugs, because what you often have is a child who's on 8, 9, 10, 11, 12 drugs. Once you get more than about 3 or 4 drugs, your quality of life will get worse with everyone that's added in, because it'll just be too complicated for everyone. I think that's me done, Karen.
Perfect.